who is the Emeritus Professor of Neurosurgery at the Seoul National University College of Medicine, a post he's held for many years, and a man who's written and published extensively on medulloblastoma, moyamoya disease, embryology, neural tube defects, and brain neoplasms. The chairman and moderator for today's debate is none other than Professor K-C Wang, and it gives me great pleasure to introduce to you K-C, and K-C, it's all yours from this point of time onwards. Welcome to this debate.
Hi, everyone. Thank you for the introduction, Sandeep. It is my great honor to moderate this clash of titans regarding selective dorsal rhizotomy, SDR. Today, Dr. Aquilina, UK, and Dr. Tovar-Spinoza from USA join this debate. Thank you very much. Before starting, I would like to let you know that during the lectures, you can send the questions by your chat box, and after 2 talks, I may select the questions and ask the speakers. The first speaker is Dr. Aquilina, UK. I will briefly introduce him. Dr. Aquilina is a consultant pediatric neurosurgeon at Great Ormond Street Hospital in London, UK, where he is the neurosurgical lead for neuro-oncology. He completed his neurosurgical training in Bristol, UK, and was appointed consultant pediatric neurosurgeon at Franchise Hospital, Bristol in 2010, and subsequently at Great Ormond Street Hospital in 2012. During his training, Dr. Aquilina completed a 1-year clinical fellowship in pediatric neurosurgery, and particularly in pediatric neuro-oncology at St. Jude Children's Research Hospital in the United States. He also spent time at the Center for Cerebral Palsy in St. Louis, where he learned the single-level selective dorsal rhizotomy procedure. Dr. Aquilina also completed a 2-year period of original research in neuroprotection of the newborn brain and the management of neonatal intraventricular hemorrhage and hydrocephalus, leading to his MD degree from the University of Bristol. His main clinical and research interests are in neuro-oncology, neonatal hydrocephalus, and the surgical management of spasticity. Today, he will talk about the positive aspect of selective dorsal rhizotomy, SDR. Thank you, Kristian, for joining this debate. Would you start, please?
Thank you very much, Professor Wang, for that very kind introduction. I'll share my screen, and you can see my slides.
Good.
So I wanted to talk a bit about spasticity and cerebral palsy, a very brief overview, and then from there move on to SDR, its rationale and surgical technique, and then consider outcomes in ambulant and non-ambulant children, and at various points, as much as possible, try to compare with ITB. The spasticity is quite a big problem in cerebral palsy, and this is an old picture describing what used to be called Little's disease. You can see how this child needs to be supported. He's got a flexed posture. His knees are flexed. He's an equinus, and there's also internal rotation of both lower limbs. And this is typical spastic diplegia. Of course, spasticity is not the only problem in cerebral palsy. These children are also very weak. They also have motor planning problems. And over time, because of the spasticity, the weakness, and their other issues like loss of balance, they tend to develop deformity, and with time that leads to progressive motor impairment. So just to put this discussion in perspective, there's many other options for treating spasticity. The aim being to reduce tone, but also to try to preserve and, if necessary, correct alignment. So children can be given oral drugs such as baclofen or tizanidine. Almost all children we see have had physiotherapy and orthotics. They get botulinum toxin injections in the lower limb muscles. And then, depending on their severity, they move on to more intensive treatments, which could be selective dorsal rhizotomy, intrathecal baclofen, or orthopedic surgery. Just a very brief comment about the causes of cerebral palsy. So we know that cerebral palsy implies an injury to the brain just before, around, or just after the time of birth or in infancy. And we know that spinal cord reflexes are intrinsically hyperactive, and it is the brain which reduces their hyperactivity and allows coordinated mobility. So in cerebral palsy, when the input of the brain is reduced, these reflexes remain hyperactive, leading to high tone and what we describe as spasticity. It's important to remember as well that the motor effects of cerebral palsy are categorized in various types, and the GMFCS way of classifying cerebral palsy is very useful. You have the level 1, who is almost a normal child, and then level 2, who is an ambulant child but needs some help walking upstairs. Level 3, these are children who tend to walk with some assistance. Level 4, these start to become non-ambulant. The severe level 4 children are less ambulant and perhaps not ambulant at all. And the level 5 children are quite unable to do anything for themselves and are very dependent on external care. So the rationale of selective dorsal rhizotomy is to try and break down this reflex hyperactivity at the spinal level. So all the impulses going in from the muscle spindles to the spinal cord are causing hyperreflexia and spasticity. If you reduce some of that input by dividing some of the afferent sensory nerve roots, then that spasticity is reduced. And this is clear both from clinical and in the past from preclinical studies. Just to review the surgical technique of SDR, it is not a new technique. It's been around for a long time. So Forster in the 1910s had done quite a large number of SDRs. There were significant issues with post-operative meningitis, but the patients he did lost their spasticity. They did not retain much of their power, and they were not ambulant, but they did nevertheless lose their spasticity. SDR was then popularized extensively by Peacock and Ahrens in Cape Town and subsequently in San Francisco in the 1980s. And that is now considered to be the traditional form of SDR, or the multi-level type of SDR. And then Dr. Park in the 1990s in St. Louis developed this further as to a single level SDR at the conus. In the traditional type of SDR, a multi-level laminectomy or laminoplasty is carried out, usually 4 or 5 levels. The dura is opened, and the nerve roots are identified as they come out of their own foramina. And by doing this, of course, you would know, because you know which level you're at, you would know which nerve root you are dealing with. It is quite a big operation, although I'm sure this is controversial, but in general, it is quite a long incision. But more importantly, there is quite an extensive muscle stripping of the back, and this is painful for a while, and it takes children a few days to recover from this. The new technique, which involves a single level laminectomy at the conus, has been developed by Dr. Park in St. Louis in the 1990s. And it takes advantage of the anatomical fact that at the level of the conus, if you can find out exactly where it is, then all your cord equina nerve roots should be there available for assessment and stimulation and for division. And by doing that, it reduces a fairly large operation in a small child with cerebral palsy to a much smaller operation. And we think this is more tolerated, especially by more dependent children, the GMFCS 4s and 5s, and also allows a rapid return to activity and physiotherapy. The key thing, of course, is to find the conus at surgery, and we do this using ultrasound. So with an initial fenestration, usually at T12L1, you can identify the conus within its own cushion of CSF, and that is a sagittal view. And on the axial view, you can also see it very well as a sensory nerve roots above and motor roots below. And this is the level of the conus where it starts to become the phylum. Of course, it's all done with neurophysiology, hence the selective part of it. And the importance of neurophysiology is that the EMG allows you to confirm that the roots are afferent and you are certainly not dividing any motor roots. You can also identify which nerve root you're dealing with, even though you cannot see it coming out of its own foramen. And by using a technique that was initially described by Dr. Park and by Fasano, but before that, you can determine which nerve roots are most likely to be contributing most to the spasticity, and those are the ones you want to divide. In our practice, we now use also BCR monitoring. We know that incontinence is a significant risk of SDR, and by doing BCR monitoring, you can make sure that you remain safe without dividing too much of the S2 nerve roots. And these are some operative photographs. I didn't think there was enough time for a video, but you can see there's a single level laminectomy here. We now usually put the bone back and secure it back, so to try and reconstitute the anatomy of the spine as much as possible. This involves retraction of the afferent nerve roots and visibility of the conus on the side. The afferent nerve roots are then slung, and the peacock probes are then used to systematically evaluate the nerve roots. And it is almost like a homunculus. If you start from the lateral aspect of the nerve root bunch, you will have the upper nerve roots, that's L1, L2. And then as you go in more medially, you come to the S1, S2 nerve roots. So it is quite easy with the assistance of EMG to identify which nerve roots you are dealing with. Of course, like any surgical procedure, there may be complications like CSF leaks. They may get some numbness, and the older children will complain of this for a few weeks after the surgery. Some of them get some transient dysesthesia, which could be uncomfortable, often responsive to gabapentin and never permanent. Bladder dysfunction I already mentioned, and I think with BCR and careful division near the level of the sphincters can be avoided. Of course, they do get some transient lower extremity weakness, hence the importance of postoperative physiotherapy. There's quite a lot of literature about the risk of progressive scoliosis after SDR, and I must admit, I think that with a single level laminectomy, which is then replaced at the end of the procedure, I think that risk is very low. Outcomes in this sphere has been quite challenging. There's many outcomes, some are difficult to measure, but the most important outcomes, at least for to assess functionality of these operations, is spasticity, so Ashworth scores, motor function, usually GMFM 66 or 88, and quality of life, like the CP-QoL or some other similar pediatric quality of life evaluations. These are also important. So most serious would report how many children went on to have orthopedic surgery, for example, how many developed hip instability or spinal instability. And also the International Classification of Functioning, Disability and Health has been promoted by WHO in recent years, and this is becoming more important as a way of reporting outcomes. But nevertheless, the most important outcome is the GMFM. And as you know, there's 5 dimensions of the GMFM, A, B, C, D, E. And these relate to activities that the children can do. This is a test which is done by physiotherapists. Usually takes about 3 hours, 2 to 3 hours to do. And it's a very accurate way of determining the ability, the motor ability of a child before and after surgery. So the evidence for SDR comes really from 3 randomized clinical trials which were carried out in the late 1990s. They took place in Toronto, Vancouver, and Seattle. In brackets here, you have the number of patients. And the data was collected at 2 years. Immediately you can see these are small numbers. Follow-up is short. This is not a perfect science, but this is the only good evidence that we have at the moment that is essentially randomized. The other complication to these studies is that there was a variable extent of sensory root transection. So the Seattle group, for example, had a significantly lower level of root transection, up to about a mean of 30 to 40% compared to the other 2 centers. And the meta-analysis was carried out in 2002, and it showed that there is no question that SDR reduces spasticity. So the black boxes are post-op. These are the 3 centers, and this is the meta-analysis. So clearly, post-op, compared to the children who had only physiotherapy, SDR with physiotherapy together reduces spasticity significantly. But of course, it's not just about spasticity. It's also important to evaluate motor function. And looking at GMFM, the Vancouver and Toronto groups showed a significant improvement in the children who had SDR. The Seattle group, probably because the division rate was lower, had a lower level of improvement. But the meta-analysis showed that the improvement actually was still significant. And this is a an important point in evaluating SDR outcomes in the long term. So of course, it was only a 2-year study. We now have some longer term data, in particular the Peacock data. The initial patients who were operated in San Francisco and Cape Town are still followed up. In particular, the Cape Town series are still followed up now even at 30 years, and the team there usually publish a paper about every 5 years to update on their development. And then this is probably the best, one of the very best long-term outcome papers for SDR from Montreal. And just to show some results from there, they've got a number of patients who've been followed up down to 15 years. Note, of course, the number does decrease over time. But if you take a 10-year outcome with 51 patients, that's quite good. And they show here that the spasticity initially, of course, is very high. That's why they did the operation. But as you come down, by 1 year, it's come down completely and it remains. So it's an operation which works not just for a short time, but its effects remain for a long time. And similarly, if you look at motor function, this is again a similar graph of the same patients using the GMFM. So this is the total GMFM level. It continues to go up over 1 year, and then 5 years, and then it reaches a plateau between 5 years and onwards. But it's interesting to see that it doesn't drop again. It remains high. So it's important that perhaps SDR can improve children and keep them at a higher level as they grow during childhood. And this applies not just to the total GMFM score, but also to the subtypes, to the subdomains of the GMFM scale. So they improve in standing, walking, running and jumping, lying and rolling, sitting and crawling and kneeling. And interestingly, if you divide those patients by GMFCS, so as we said before, the GMFCS1 are almost normal children, but have some spasticity. These are the 2s, the 3s, and the 4s. We can see that all of them, even the 4s, will actually improve with SDR in a way that their improvement is maintained. And you could argue that GMFM is still not the most important outcome, but activities of daily living are more important. And that is probably true, that you want to assess how they manage their self-care and mobility as assessed by a questionnaire given to the parents and as they get older to the children themselves. And you can see that both self-care and mobility improve and remain higher over time with SDR. And many papers have also reported on functional changes. So there's a decrease in lower limb pain. Some of the children wouldn't even know they would have been uncomfortable before the surgery, but the older ones tell you that the legs now feel much more comfortable than they had been before. Their sleep improves, and also for reasons we don't completely understand, their upper limb function and fine motor skills also improve. Of course, patient selection is key. And if you look at the GMFCS levels again, SDR is best for levels 2 and 3, and perhaps for some level 4. We usually consider level 1 patients to be too good for SDR, but nevertheless, if they are very spastic and they have good function, then SDR could still be an option. And these criteria for patient selection are very similar to the criteria which were used in the 3 trials we spoke about a few minutes ago. So the selection criteria for SDR really hasn't changed very much over the years. And to list them, it essentially is spastic diplegia related to cerebral palsy. They're usually over 3 years of age, although that is debatable. Some units are happy to operate even over 2 years of age. Most of these children are born preterm and have periventricular leukomalacia. And it's important to see that the MRI scan does not show any major injury to the cerebellum, basic ganglia, or brainstem. They should ideally have no dystonia. They need to have generalized lower limb spasticity with high Ashworth scores, and they have to have adequate muscle strength in legs and trunk. The hips also need to be stable. We'd like to see Reimer indices under 40%. Now, of course, there is some literature about ITB in ambulant children, and this is one of them from 2008, where 21 ambulant children and young adults had ITB for at least a year. And in these, the Ashworth score also decreased by 1.4 points, and 7 out of 21 children were able to use less supportive walking aids. And this is a study where children who are ambulant and had ITB went on to have a gait analysis test. And you can see that although there was an improved muscle tone and improved knee flexion, they did not improve gait speed or gross motor function. Moving on to non-ambulant children, this is perhaps the scenario where most people would consider ITB. They form the established selection criteria for ITB. These are the GMFCS 4s and 5s. These are children who have dystonia, and also children who have upper limb involvement. What we have to ask the question here for the purpose of this discussion is, as they are useful in these children. It's important to remember that the objectives are different. So these children are non-ambulant. So the important thing is to make sure they are pain-free, they have good floor mobility, they have good posture, and the care given by their carers is facilitated. And these are some results from our series of GMFCS4 children we've done here. We've done about 35 of these now. And you can see that the GMFM domains, you can see that the Ds, that's standing, crawling and kneeling, and to some extent sitting, these improve over time. And if you compare that to the GMFCS2s and the GMFCS3s, of course, the GMFCS4s are starting at a lower level. But even so, the trajectory of improvement is quite interesting and suggests that SDR may be helpful in these patients as well. And from our experience, at least, we can say that SDR reduces spasticity in GMFCS4 children very effectively, and it's long-term. We see improvements that are most marked in floor mobility and posture. And none of the children we've done, admittedly carefully selected, none of these have deteriorated. And you can see one such child here where you can see in pre-SDR, he's trying to sit, but needs to hold his hands to balance. He's slouching forward. And then only 4 months post-SDR, you can see his posture is better. His legs are crossed in a more comfortable way, and his hands are now free to play, and his spine is more straight. And we think that those are important changes that you can obtain with SDR in these GMFCS4 children. So of course, there's been some literature on SDR in GMFCS4 children, and in this particular study, in GMFCS4 and 5, 54 children underwent SDR, and they showed improvement in spasticity over 1 year of follow-up, and they also showed reduction in upper limb spasticity and improvement in urinary continence. And this is probably the best available paper on a comparison between SDR and ITB. And you can see that in these children between GMFCS 3 to 5, so mostly non-ambulant, perhaps with a few who are slightly ambulant, both procedures, both ITB and SDR reduced tone and improved function. But SDR was felt to lead to a larger magnitude of tone reduction and improved range of movement. And there were fewer orthopedic procedures in the SDR group compared to the ITB group. Similarly, in this paper from Nottingham, this paper involved 10 children with high-grade GMFCS, where because the ITB had to be discontinued, either because of infection of the pump or because the pump battery ran out, it was decided to not continue with ITB, but change to SDR. And the experience of this group was very positive, with a reduction in spasticity. It was maintained and was even thought to be better. There was no loss of leg power, improvement in activities of daily living in 70%. And this led to a change of practice of this particular team. And also important to keep in mind that there's now 2 series which show that selective rhizotomy can also be applied to the ventral roots. So I personally haven't done any of these yet, but it is an option. Of course, GMFCS 4 and 5 children have severe dystonia. And if they have mixed spasticity and dystonia, then division of some of the motor roots could potentially reduce their dystonic activity. Just to finish, some additional considerations. So as Professor Wang said in the beginning, suitability for low-income countries is important, and therefore cost is important. And as I'm sure you're aware, academic rigor in the field of cerebral palsy is quite difficult. There's no high-quality comparative studies. There's no high-level evidence. All studies are very heterogeneous, which makes meta-analysis very difficult. So one has to interpret the literature with a lot of care and a lot of basis on one's own personal experience as well. So just a couple of thoughts on cost and complications. There was one paper about the cost of ITB from 1995 in Vancouver, where 9 children had ITB and 10 had SDR. And the costs of ITB were significantly higher compared to SDR. 64,000 Canadian dollars compared to 17,000 Canadian dollars. And this is probably related to the fact that all ITB patients need a test dose and need to be in hospital for a while around that as well, and also related to complications. And there were 5 additional procedures, as well as some admissions for dose adjustment. And complications in ITB, I think, are well known. We all struggle with them. So things like catheter disconnection, dislodgement, infection, CSF leak. And this paper, the second paper, shows also a Kaplan-Meier curve, which shows that perhaps a bit like shunts, baclofen pumps have a survival curve. They don't stay forever. They need to be changed, or they need to be revised when complications arise. So to conclude, I would very carefully say this, but I think that if a child has dystonia, GMFCS 4 or 5, then ITB is better. And if a child has predominant upper limb spasticity, then ITB is probably better. But I would think that SDR is probably suitable or could be considered for anyone else. Thank you very much. You may be muted, Professor.
Thank you, Kristian, for your clear presentation. Before the start of second talk, I would like to ask Kristian to differentiate the diplegia and paraplegia for the resident audience. Some of them questioned about what is the diplegia.
So we call this spasticity in cerebral palsy as diplegia. Paraplegia is predominantly weakness, whereas diplegia is predominantly spasticity. So the sort of the syndrome which is associated with CP and which is associated with prematurity and periventricular achalasia is diplegia rather than paraplegia. So they have strength, they have power, but they are very stiff.
Thank you. The next talk will be presented by Dr. Zulma Tovar-Spinoza. She'll talk about the other side of the SDR and the role of the intrathecal baclofen ITB for the management of the pediatric spasticity. I will briefly introduce Dr. Tovar-Spinoza. Dr. Tovar-Spinoza is an associate professor in the Department of Neurosurgery, Department of Pediatrics, and Department of Neurology at SUNY Upstate Medical University in Syracuse, New York. She also serves as the Associate Dean for Diversity and Inclusion for the College of Medicine. Dr. Tovar-Spinoza obtained her MD degree at the Universidad de los Andes Medical School in Venezuela with cum laude honors. Dr. Tovar-Spinoza entered the Rabin Medical Center Neurosurgery Training Program in University of Tel Aviv in 1997 under the supervision of Professor Rappaport. She was the first female resident accepted to this program. Upon her board certification by the Israeli Society of Neurological Surgery in 2005, she completed fellowships in pediatric neurosurgery and pediatric epilepsy and epilepsy surgery at the Hospital for Sick Children in Toronto under the supervision of Professors Rotka, Drake, and Snead. In 2009, she assumed her appointment as Director of Pediatric Neurosurgery at the Department of Neurosurgery at SUNY Upstate Medical University in Syracuse, becoming the first female faculty in the history of the department. In 2015, she was promoted to Associate Professor in the Department of Neurosurgery and Pediatrics, and most recently, Associate Professor of Neurology. Dr. Tovar-Spinoza's research and clinical interests relate to the surgery of all fields of the pediatric neurosurgery, including pediatric brain tumors and epilepsy, hydrocephalus, endoscope, spasticity, congenital malformations, and brain trauma. All these multidisciplinary programs have been established and further developed during her time at Upstate. Under her leadership, the pediatric neurosurgery program at Upstate has escalated to be regionally, nationally, and internationally recognized. We are going to listen her talk on the other side of the SDR and the role of the ITB. Zulma, would you start, please?
Well, thank you very much for the kind introduction. So let's talk about a little bit about the ITV therapy. Oh, let me see. What is this? It's not moving. All right. And disclosure, I want to thank Medtronic for contributing with some of the data. Let's give a little bit of a spasticity overview just to complement what Kristian just said for the persons that are listening to this talk. Obviously, the range of muscle tone comes from flaccidity, goes to hypotonia, to the normal range of muscle tone, hypertonia, spasticity, to the most severe form that is rigidity, which is what we are trying to avoid when we do all these procedures. What is spasticity is nothing else that is balance. It's an abnormal increase in the muscle tone by any kind of injury, either cerebral injury or spinal injury. And these neurons are just going to be hyperexcitable, and there is resistance to the passive stretch. And this causes several problems on these patients. As I said, it's a disbalance between the descendant and ascendant inhibition, and it's hyperpolarized by a sensory excitation or many other reasons. The pathophysiology, I won't go in this in detail, but again, there is on the cerebral origin, there is a normal brain that delivers inhibitory neural spines to the spinal cord. And when the signals that are okay, the tone remains normal. In the damaged brain, the lack of neural inhibition is going to leak to a spasticity. And the same happens when we have spasticity from the spinal cord. So we need to figure out ways of how to control this. There are advantages of spasticity on these patients. Spasticity is not all bad. In some of the patients, spasticity actually helps to keep the patient at the muscle tone, supports some circulatory function, may prevent the formation of DVTs, and may assist on some of the daily activities. However, spasticity will also interfere with the mobility, with exercise, the joint of range of motions, with the daily activities, with the transfer, cause a lot of pain in some of the patients, sleep disturbances, and the patient care can become progressively more and more difficult. Spasticity is mostly caused by a spinal cord injury, closed head injury, stroke, and cerebral palsy. In cerebral palsy, the main cause in pediatrics. And as we said, can be incomplete, complete, tetraplegia, paraplegia, et cetera, et cetera. And this is just some slide to show you the big numbers of, this is in the United States for cerebral palsy, the big numbers that we manage, and why this is a health problem that affects us all, and why we dedicate so much time to try to figure out how to treat this condition. Obviously, as I mentioned, cerebral palsy is the most common cause of spasticity in children. The more that we keep these premature babies have better techniques where keeping them survive. They usually have very ventricular leukomalacia, and they survive longer. And most of these kids, we will have cerebral palsy. Therefore, we have been found ourselves trying to find techniques of how to treat their spasticity. The assessment, as we say, spasticity is one of the upper motor neuron syndrome. Patients can have exaggerated cutaneous reflexes, autonomic hyperreflexia or dysreflexia, which can be actually a lethal situation if we don't know how to treat it. Dystonia, contractures, spasms, symptoms of paresis, fatigue. So the upper motor neuron syndrome is not going to cause you spasticity, but it's going to cause you many other factors that also need to be addressed, either medical or surgically. So positive signs will be spasticity, rigidity, hyperreflexia, primitive reflexes, conus, and the negative signs will be lack of strength, lack of motor control, lack of coordination, and fatigue. And I will say also the hypercaloric span of these patients. There are factors that may increase the spasticity. There are uncontrollable factors as simple as urinary tract infection, kidney stones, menses on females, bowel impactation, DVTs, pneumonia, wounds or infection, and progression of disease. There are the factors that we can medically control, or the treatment controlled by stress, ingrown nails, clothing, fatigue, psychological factors. Changing heat and humidity can also increase the spasticity and body positions. Again, it's many factors that are affected by spasticity, mobility, pain, restricted ADL that are important for transfer, but also for hygiene, especially in patients that become so contracted that you cannot even open their hands and they develop fungal infections. Deformities, orthopedic, the need for orthopedic surgeries, the need for increased caloric intake, the quality of life, not only of the patient, but also the caregiver, the mental health of the patient, because not all of the patients that have CP have developmental delay, and the cost of care. Does spasticity change? Yeah, there are physiological factors that can alter the intensity of spasticity and the functional abilities of his patient, right? As I said before, pain, infection, and distended bladder and bowel. And the consequences of all of that in the long term is the negative impact on the patient, on the caregiver, the decrease in the quality of life. But also we need to consider that some of the patients are going to take oral medication to try to help them, but they also have significant side effects of this. And Botox injections in some cases are not practical in management, especially in some of the pediatric patients. There are many ways of measuring spasticity, and I'm just going to go quite briefly over this, by measuring muscle tone, joint, muscle stretch reflexes, strength and motor coordinations, and we all are aware of the modified Ashworth scale and the other scales that depends on the groups in your hospitals are using, and I'm just mentioning them today. But then it's the decision-making of the team of when and how to address every single patient with spasticity. We have goals, and obviously the goal is to decrease the spasticity, improve the functional ability, the independence of this patient, decrease the pain, because these patients really experience a lot of pain, decrease the contracture, which is the end result of the non-treated spasticity, improve their ambulation and being in independency on the daily activities, facilitate the hygiene and ease rehabilitation procedures, and obviously to save caregivers' time. There are many treatment options, and none of them is exclusive of the other one, but we have the general ones where we can use oral medications, the intrathecal baclofen therapy, PTOT, ST, although the therapies are applying for all of them, and the injection therapies. And on this side of the screen, we see options that are reversible, and that is important. These are reversible. We can manipulate those. Well, in this side, we have the selective dorsal rhizotomy and orthopedic surgeries, which are permanent and non-reversible treatments. The traditional approach to manage spasticity is to remove the noxious stimuli, go to rehabilitation therapy, go to oral medications, try some neurolysis procedures, orthopedic procedures, and then neurosurgical procedures. Obviously, this is a multidisciplinary approach that we manage within a team that manages spasticity in your hospital. You start with oral medications. Again, oral medications are reversible and non-invasive and may be effective for some patients. However, the great disadvantage of the oral medications is that these patients usually are going to end up needing high dose of medications, and they are going to have the potential side effects of them that are drowsiness, hypotonia, weakness, lethargy, and altered mental status. These are the common oral medications that we all have in the armamentarium: baclofen, diazepam, Dantrium, and tinazidime. We can also use local therapies or local injections that are also reversible, but can be relatively expensive depending on the drug, but we can use them in conjunction if we can use it on multiple joints, and may be helpful during the growth spurts in children. One of them is phenol that can be used in conjunction with the Botox injections. Orthopedic surgeries that we see that they are useful in patients that have contractures, especially in the legs. They are not uncommon, and they are important to know before we decide for intrathecal therapy versus dorsal rhizotomy. And spasticity will likely reoccur unless the patient is well treated and has well orthotic treatments afterwards. Then in these procedures are tenotomies, tendon lengthenings, myotomies, or tendon transfers. From the neurosurgical perspective, there are many treatments that we can use, and that have been described, but literally we don't do these very wide procedures anymore, but we refer now to selective dorsal rhizotomy, as Kristian just said, either the multi-level, which was the way that we started, versus the single-level rhizotomies. So I'm not going this. This is the selective dorsal rhizotomy. This is sectioning of the dorsal lumbar roots. It's non-reversible, and I go back to this. It's irreversible. And it's clinically and classically the standard of care for the spastic diplegia person. And usually combined with very intense physical therapy, which needs to be explained to the parents in the moment of presenting these procedures. Again, the selectors have one of these characteristics, ambulatory spastic diplegia. The other comorbidities associated with this patient, like dystonia, athetosis, or ataxia, are actually excluding factors for this procedure. And they have to be participative in a post-op therapy regimen, because we all know that the surgery per se is not going to make the magic. The surgery is going to help, but if the patient doesn't follow an intensive rehab plan, then the surgery is not going to be as successful. This is just the indications that Kristian already mentioned. And I'm not going to go through this. And this is the pictures from the famous Dr. Park's paper explaining how he does his single level rhizotomy. Now, if we talk about intrathecal baclofen, we know the baclofen is a GABA agonist. So it's a GABA receptor agonist, which means it's inhibitory of the CNS neurotransmitter. The mechanism of action is not fully understood, but we know that it believes that it release excitatory neurotransmitters by inhibiting the calcium influx on the presynaptic terminals. So it's going to reduce the spasticity. Patients usually start with oral baclofen, but the problem with the oral baclofen is that the patients actually are going to need 100 more doses that they will need with the intrathecal dose. The half-life is only 3 or 4 hours, and therefore the patient needs to get this several times a day. And there are patients that can get up to 60 milligrams every 4 or 5 hours a day, and the patients become really sleepy. The intrathecal baclofen is, as I said, is much more smaller doses. Half-life is 4 to 5 hours, eliminates by the CSF turnover, and the delivery of the drug is usually consistent because it's a continuous infusion. So the patient is not going to have peaks or variation on the clinical aspects of the spasticity. Again, the ITV therapy it's delivered to the intrathecal space. The levels are lower, therefore there are less collateral effects, and is safe. It has proven to be a safe procedure. It creates a higher drug concentration at the level or the target of receptors, including papers are saying that this depending on the level of the catheter in the spinal cord, you're going to find higher concentrations of baclofen in that area. Therefore, when you pass this catheter all the way up to the upper thoracic, you can also have an effect on the hands, which is very important on these patients. And the intrathecal delivery may reduce the central nervous system effects of the baclofen. The half-life, as I said before, is 3 to 4 hours, and reduces, I already said this, that reduces the side effects. It treats patients is classically indicated for patients that have very severe spasticity. And remember, we also have patients not only with CP, but also patients with post-stroke, multiple sclerosis, brain injury, spinal cord injury, and cerebral palsy. the patient selection is important. There is a screening test that needs to be done, usually done by the rehab team. The patients need to have a surgical candidacy for the implants and also consider what is going to happen with the maintenance. So we pick patients that have severe spasticity, usually multisegmental of any origins, that interfere with daily activity lives. Obviously, they are unresponsive to oral antispasmodics or have unacceptable side effects of oral baclofen. The therapy with the implantation, I'm going to talk about it next. And it's important for being positive to the screening test. And that to date, the effectiveness of the patients under the age of 4 has not fully been established, but there are also limitations on the side of the pump. Okay. Again, it's identifying the appropriate candidates and review with the clinical team. We do a screening test that allows the patient to try intrathecal baclofen before committing to an implant. And all these patients have showed that there is a significant improvement before making the decision. The possible related side effects of the intrathecal treatments are hypotonia, somnolence, nausea, vomiting, headache, and dizziness. And obviously, like every single surgical procedure, is contraindicated in the presence of active infections or patients that have hypersensitivity to the baclofen. The onset of effects are going to be seen 1 hour after the bolus with a peak 4 hours and a duration of 4 to 8 hours after bolus. And then you need to monitor for possible side effects. And this is the way that the screen test flow chart is done. Prior to the test, it's important to determine the effect of spasticity and function, but there's also assess the parents about realistic expectations, communicate to the physician and the response to oral medications, and set goals for the screening, implant, and long-term therapy. And that will vary according to your local support team. And this is, again, the screening test, assessing the screening test results. Obviously, the patient is to show a positive response in decreased spasticity, differentiate the contractures from hypertonia. The screening test does not assess function. It's just assessed the decrease of spasticity. And muscle placidity is not a contraindication for ITP. This is the way that the pump, it looks. It's still a big pump, but we have two sizes, the 20 mLs and the 40 mLs that is placed subcutaneously in the abdomen, and the catheter that goes, connects from the intrathecal catheter to the desired level in the back. And the pump and catheter are surgically anchored, and we have this programmer for which you can program the pump from outside. And obviously the intrathecal baclofen. The battery life is approximately 5 years, depends on the rate of use. By the end of the 7 years, you just need to open the pocket and change the pump. The catheter has been modified through the years, and it initially was a long one-piece catheter. Now it's a two-piece catheter that is pre-attached and connected to the pump. The implant procedure is very simple. What I always recommend is to look at the patient before and look at what is the weight that the patient daily activities, or if the patient is wheelchair bounded, to see if the patient has scoliosis, which side, the pump being the size of the pump, notorious, the pump is not gonna touch the ribs or the iliac bones. That is not gonna cause any pain afterwards. And then you mark the surgical site, put the patient lateral as when you're gonna do an LP, make your abdominal incision, and then you put the pump on that pocket, but you're gonna connect and you're gonna just position, make an incision in the back and introduce the catheter like a lumbar puncture and just connect the two devices. And the surgical procedure is quite very well described. You just need to go a little bit in an angle to avoid, and it's important in these patients because of the spasticity, you need to go in an angle just to avoid fractures of the catheter between the vertebrae, or the patient has scoliosis and have already some fusions. You need to sometimes go there and drill a little bit to avoid this catheter to be dislodged or be kink. Although the new catheters are much more stronger than the previous one. And the pocket is usually some patients, if you have a patient that has enough fascia, you can put it subfascial. If not, put it in a subcutaneous tissue, should be okay. Obviously, after you finish this, you need to check with the patient overnight, and with your rehab team to check any signs of overdose, dizziness, drowsiness, somnolence, hypothermia, respiratory depression. And that's why this main reason that this patient needs to stay overnight in the hospital, just to make sure that the doses they are delivering are not causing any life-threatening condition. There are also patients that come with withdrawal symptoms, and these pumps have a safety beeping that when the pump is not working, the pump starts beeping and notifies the patient and the family that there is some malfunction. And this is important because withdrawal from baclofen can be a life-threatening condition, as I said. The titration of the patient is progressive. So this is another advantage of the ITV therapy. You start with a low dose, and like every medication, you just start titrating. And that's what I like from this option, is that you can monitor and modulate the response of your patient. The communication between all the members of the team is very important. And again, this is not a one single person decision. The surgeon is just only one person on the whole puzzle of treatment for this patient. Most of these patients, like the same as SDR, are going to require significant rehab that is going to focus on the elongation of the shortened tissues, the straightening, improving motor control, endurance, and functional training. They're going to need equipment for supporting these functions. And they are going to need complementary therapies. Once you use this one, that doesn't mean that you can exclude the other therapies. You can go back to other therapies and complement these therapies to improve the function of the patient. And this is the way that the titration happens afterwards. In adults, the titration is faster. In pediatrics, you just go for 5 to 15% increments every 24 hours. Now, when we compare techniques, obviously we talk about the oral medications and the bolus injections. Those are reversible, and they just, when the patients fail these ones, then you try to go to baclofen or you consider rhizotomies. Okay, so if we look at the candidates, obviously baclofen pump has been classically included for patients with spastic quadriplegia or spastic diplegia, but they are also patients that have comorbidities, not only spasticity. And there is a significant outcome on the decrease of spasticity, the improved speech, activities of daily life, and decrease on orthopedic operations, and is reversible, which is doesn't happen with the rhizotomy. The infection rate described on this paper is 5 to 10%, depends on the hand. And this is the cause that, as Kristian just presented, with hospitalization and initial medication. As I said before, the pump replacement is 5 to 7 years. And this is the rhizotomies, a classical indication, spastic diplegia, with patients that actually have a good leg strength, no severe contractures or severe leg spasticity. This is not an adjustable or not a modulating therapy. When you do it, and the patient becomes weaker, and you're going to need to, the patient needs to be compromised to an intensive physical rehab to return to the strength, their strengths are helping with the daily activities. Rate of infection is described a little bit lower, and the cost of the hospitalization and surgery, let me just move this, and following surgery is this. So I will talk more about that in the next slides. So I went and asked, this is the cost, the actual cost of the trial of baclofen pump in my hospital. So when you do the trial, this is the cost of around $600. The procedure itself is about $1,600, $1,700, and the pump and the catheter is about $1,100. And then you need to consider that these patients are going to need refills, and patient per refill, the potential reimbursement is about, depends on the insurance, $180 to $200. So I went to look into literal research between this difference between ITV and SDR up to March. And as Kristian mentioned, the only paper that actually exists that has compared apples to apples is the study from Can that compared spasticity outcomes between matched groups of patients who received ITV therapy or underwent SDR. And although they proved that SDR provided a larger magnitude of improvement in tone, of range of motion, of gross motor function, there was no significant difference in the degree of parent satisfaction, because that parent satisfaction was just measured related to each procedure, but not in comparison to the procedures. And as the goal of SDR is the improvement of care, the improvement of care was not measured on this paper. Also was not mentioned on this paper the improvement of the upper extremities, which is extremely important when we are going to compare both of these techniques, given the classical indications of the SDR for the spastic diplegia. And although this is a very strong paper on the fact that it compared apple to apples, is also weak on that regard, but also weak on the factor that it didn't analyze was the potential confounding factors that may influence outcome, like patients' comorbidities, like spasticity and dystonia, effects of dystonia, the intensity of postoperative PT, and patients' motivation after surgery or concurrent medical treatments. So it's a partial good news about SDR, but there is a lot of data that has not been analyzed on this paper. Silva and al. just presented also a study about looking into the orthopedic procedures after ITP and SDR, and they didn't see any significant difference, as you can see here, between the two procedures in the long term of patients that they needed surgery for hip dislocation. Right, and we don't know this paper. This paper didn't compare the ITP to SDR. More recently, Davison published a systematic review for ITP therapy versus SDR in non-ambulant children with CP, which is what Kristian was referring to, the patients that now have a higher score on the GMFCS. And that was also described by Aquino. So yes, there are some suggestions that these patients can improve the motor and the, as he mentions, the motor function and the spasticity. These patients, this paper does not compare apples to apples. And it's just a suggestion that this is happening, but it's not, there is not really clinical, there is evidence that can reduce the spasticity, but there is not total evidence that is measuring all the factors or all the advantages of this. Morota published a review in 2015 that supports the use of ITV therapy in Japan. And Novak presented a systematic review for children with cerebral palsy. The survey recommendations for just to analyze different interventions, including the ITP and SDR. On regards of the cost analysis, there are several papers that will support that the ITV therapy substantially decrease the healthcare resource over time. And it can become cost effective. Again, that depends on where your environment is. But Treasured published in 2003 that nearly 2/3 of all the societal costs of care for these patients are not actually related to the pump, but are actually related to the inpatient encounters. And a small number of patients represented high number of medical encounters and associated costs because of that. So this is something that we need to look into when we talk about, okay, is the procedure itself that is causing the increase of care. Hattori presented in 2014 a cost analysis that showed that the ITV therapy in Japan is an acceptable treatment for severe spasticity, given the improvement 5 years post-implant on the quality of adjusted life years. Steinbock in the time, as this was mentioned before, presented the comparison between dorsal rhizotomy and ITP, but again, this study did not compare apple to apples, it just compared different groups of patients individually. Obviously, there are many papers showing what is the clinical and safety evidence of baclofen pumps on patients, and that has been well supported by the literature. The long-term follow-up is also very well supported, and on this paper published in the Journal Pediatric Neurology, when at 6 and 9 years follow-up, you see that the ITV therapy outcomes are an improvement in spasticity and related to the improvement of pain, ease of care, mental health care, and they were maintained with the new improvements in parental empathic scales were observed too. So their quality of life was also improved. The study by Mota shows that patients with mild to moderate impairment, which is the levels 2 or 3, shows the most improvement in walking, while patients with severe impairment had the most improvement in care of management. Today, there are no clear studies comparing pair to pairs with patients with level 4 and 5, although those studies are just coming up between patients of ITP and selective dorsal rhizotomy. But these results obviously suggest that ITP is a supportive therapy for both ambulant and non-ambulant patients with CP. This study by Crank in 2006 that evaluated the satisfaction actually of the caregivers and the patients. The ITP improved patients' motor skills, the level of comfort, the ease of care, the ability of participating in ADLs, and also the ability to transfer to and position, walking, toileting, and dressing has the highest frequency of improvement. This is a significant factor for these patients because it's just the daily by day, minute by minute activities. The safety, yes, I know there are many papers saying that there is an increased rate of infection in comparison to SDR. However, papers like this by Mota show that, yes, if it depends also on the hands of the surgeon, there is a learning curve in doing these procedures and the protocols that you use in your institution when you do these implants. If even though their rate of infection was higher at the very beginning at 10%, according to them, that rate of infection was reduced to 4.8 after they adopted a clean surgical technique and adopted the use of pre-surgical antibiotics. So we need to look very in detail when we look at the rate of infections and where this data is coming from, because the improvement of the technique is certainly an important factor. Complication.
Yeah, would you conclude?
Yes.
Yeah.
Okay, yes, I'm just going to put then don't leave these ones. The conclusion is the next one. So the intrathecal delivery is an alternative to rhizotomy procedures in children, a standard option for patients with spastic diplegia and also spastic tetraplegia and associated comorbidities. The advantages is that it's simple, it's adjustable, and it's reversible. ITV therapy is supported by literature to decrease spasticity, improve motor function, improve individually formulated problems, easy care, toileting, mental health, and parent satisfaction. Also improves upper limb spasticity due to the effect of the cervical spinal cord, improves spasticity in non-ambulant patients. It does not increase orthopedic procedures or deformities. It's cost-effective in the quality-adjusted life for years, and the infection rates can be moderated. Thank you.
Thank you, Zulma, for your nice presentation and detailed review of the ITB. It must be quite informative, especially for those in training and young neurosurgeon. And there are 5 questions from the audience. I think the first 2 are regarding to the Kristian's lecture. The first one is how do you think about the unilateral SDR? I think somebody do the SDR for the hemiplegic spasticity, something like that. What is the position, Christina?
So there has been some papers published on this, and there is some evidence that it does help. So you're doing a unilateral one-sided SDR would reduce spasticity on that side. And of course, because you have a normal contralateral side, the rehabilitation is actually quicker. So of course, it is important to select the right patients. Many of these have perinatal infarcts. Ideally, you avoid those who have dystonia more than spasticity, but it is certainly an effective operation in the right patients.
Do you often do the unilateral SDR by yourselves?
So no, we haven't actually done any here because they're very rare actually, and the papers that describe unilateral SDRs are only small numbers.
Yeah, I agree. Yeah, the second question is the level of the spinal operation for the functional level 4-5 patient in case of SDR. Do you do the same operation as diplegia patient?
Yes.
In this patient, all the extremities may be spastic, including upper extremities. So the question is the level of operation.
Yes, you would do the same operation for GMFCS 4 and 5 patients. There's been some studies about rhizotomies for upper limbs, but the results are not very good, and it's not really in mainstream practice at all. Very, very small numbers in adults usually, which because the overlap of the roots in the upper limbs is so low, then the results are very poor. And so even for a quadriplegia, you would still do a standard lumbosacral SDR. But some of the papers have noted that in GMFCS 4 and 5 children, the upper limb spasticity does improve with time, despite doing an SDR only for the lower limbs. That's been well described.
Yeah, thank you for your answers. Yeah, I agree that the some of the patients of their level 4 or 5 have improvement of the upper extremity spasticity, even though the general spastic spasm is improved and the duration of the spasm is also shortened. Even the operation is at the lumbar area. Yeah, I agree that. Yeah, thank you for your answers. And the other 3 questions for Zulma. The first question is, how about the body weight and abdominal wall thickness? You mentioned how deep the device should be located, but the question is regarding the patient condition, weight limitation, and abdominal skin condition. What's the answer?
Well, obviously, for pediatrics, this probably applies is just to the smaller kids, right? You need to make sure that the body of the kid is going to be able to contain the pump without causing any erosion afterwards. So the weight is usually with classically described over 35 kilo, and you try to put this, obviously I try to fit this. Most of these patients have a very high caloric intake, and we really try to get them when they ideal protein condition also for healing, and that's a key. And that we showed we have grown and waited for some patients to get these conditions before we do the surgery to make sure that they can tolerate, they handle the pump.
Yeah. the other two questions regarding the pretest. One question is the repeated dose test, and in this case, do you do the L-tap, lumbar tap for every test?
Yes.
Yeah, okay. And the second one for the pretest is the when you indwell the catheter, do you do the laboratory test for infection, such as repeated cultures?
Yes, obviously we have a very strict technique, and we take test patients for MRSA, and we all our surgical procedures have a very strict process where we don't even touch the pump with our hands, and we use antibiotic therapy pre-op and post-op on these patients to reduce the risk of infection. We're very meticulous when using implants in the OR.
And you also do the same test for the indwelling catheter, I mean, for the pretest?
For the pretest, no.
No, you don't.
No.
You don't. Yeah, that was the question. Yeah, thank
Yes.
you. And there's another question received just before. Has the post-op intensive physiotherapy requirement been a significantly limiting factor for your families in deciding to proceed with the SDR? That is a question to Kristian. I think that question is the if the intensive PT is necessary, does the parent will also agree SDR or not, as I understand? What is your answer?
So I think all the parents are very aware of the need for physiotherapy. Many of them would already be doing a lot of physiotherapy. These are usually often very dedicated parents. Of course, there's always exceptions, but many of them are very dedicated. They would have therapy. And one of the main problems of therapy with spasticity is that they spend almost all their therapy time trying to stretch these very stiff legs. Whereas after SDR, they don't need to stretch the legs so much anymore, but they strengthen them and try and get them to be more mobile. So the objectives with SDR change, and the physiotherapy therefore changes. And I think most parents look forward to be able to do that. And I've never had any problem really with parents doing post-SDR physiotherapy 2 or 3 times a week for a few months.
Yeah, they are already quite adapted to the intensive PT before the surgery. Yes. Zulma, I have one question to you. And compared to the SDR, the post-op follow-up is more complex in case of ITB because of the tolerance at the initial phase. Those should be adjusted, monitoring the response in terms of spasticity control. And therefore, the early postoperative period, the patient have to visit clinic frequently. How often do the parent should visit hospital? How often and until what stage do they have to do the frequent visit?
Okay, so we work very close with our PM and our team, but with the patients that have a new implant, the patient actually remains in the hospital during the first week until we make sure that the patient gets titrated to a minimal dose that is well tolerated and it is producing not either under spasticity or under symptoms or over symptoms. And then they will remain on that minimal dose and will be there will be increments of every 2 weeks or so until they get to what is going to be their ideal dose. Okay, on the difference to the SDR patients, our patients with SDR they move from the surgical ward to the intensive PM&R for at least 3 weeks. We keep the patients, we follow Dr. Park's initial protocol where the patients actually remain in hospital for 3 weeks until in that way we can work in a very intensive way with them.
Yeah, in case of ITB, when does the dose stabilize?
Well, that is very individual on every single patient, right? But I will say that after the initial admission and implantation, probably a month, 6 weeks after the patient usually finds the right doses.
Yeah, thank you. And this is my question to Kristian. It is believed that SDR is one-time surgery. There is no reoperation. Is it true? Do you have any experience of the reoperation of the SDR?
No,
No.
I don't think you
No.
can do it. It would probably be too scarred, and it won't be possible to identify the nerve roots at that stage.
Yeah, I have 2 cases of reoperation.
Have you?
Yeah, and when I opened the previous wound, I can easily discriminate the untouched root and touched root because we do not exist all length of the root. There is some remained portion of the root, and the touched root is very thin and white compared to the untouched root. It was an interesting experience, and in my experience, reoperation is possible, but a very limited number.
Very interesting.
Yeah.
Thank you.
Yeah.
Like a spaghetti party.
This is the last question. Do you keep your patient in the ICU initially after ITB pump implant, or do you observe at the general ward after operation?
And that has been an interesting question during the pandemics and a debate between me and my adult colleague. I keep my patients on intensive care. My adult colleague has risk because we don't have intensive care unit beds. They have tried to keep him on the ward. Thanks God, nothing has happened, knocking wood. But I wouldn't feel comfortable having a patient with a new implant or even a change of the pump on the ward. These patients need close monitoring.
Yeah, thank you very much. I want to ask opinion to both of you. I often compare the relationship between the SDR and ITB to the relationship between the ETV, endoscopic third ventricular stomy, and shunting. Even though the indication is limited in the ETV, once it is successful, it is several advantages: more physiologic, no permanent indwelling of the device, and less postoperative care. Can it be applied to the relationship to the SDR and ITB? Even though the indication of SDR is limited than indication of the ITB, once the SDR is successful, they do not need intensive postoperative care, and they do not need permanent placement of the device, something like that. Do you agree?
Well, I believe that it depends on the order that you do the procedures, right? ITV won't exclude doing SDR at a certain point. When you do SDR, you cannot go back. And I don't think we have enough data comparing the long term of patients that have SDR, and we have done, at least I didn't find any paper. Patients that have SDR and eventually the SDR for some reason didn't work or didn't gave the patients the right expected results, and then the patients have an ITV implant. That will be an interesting looking on see what the experience is. I personally didn't have any patient that had SDR, that I did SDR on them and have a pump. So I think in the order of, ITV is SDR, they are not excluding, or actually in the other way, it's probably not excluding, but we don't have enough evidence to support that.
Okay, how about the Kristian?
Yeah, it's an interesting question. I never ever thought of that before. And as we said several times today, the SDR is a permanent operation and does not require an implant. I suppose the other way the other aspect to it is that even a successful SDR over time they may still require some orthopedic surgery and other ways of treating either dystonia or perhaps some residual spasticity or some deformities which would not have been corrected. But that's outside the neurosurgical domain, so to speak.
So also that I would like to add that, now that more papers are coming out with using SDR in patients with a higher level 4 and 5, probably, that's something to look into, that if these patients that don't improve the upper motor as expected, if these patients will need eventually an intrathecal baclofen pump to help with those. Something to think about.
Yeah, we may have more solid data regarding this points, hopefully. Thank you for your active participation with the beautiful lectures, and thank you for the audience. Sandeep, this is the end of Clash, and now please end this Clash with your comment.
Yes.
Sandeep, are you there?
No, is now seeing this moment. Sandeep is traveling.
Yep.
Thank you very much for the audience. Thanks, Dr. K-C Wang, for this insightful moderation and for sharing the reoperation case. Usually, we don't share our most difficult experience. And you give your insightful thoughts, comparing also baclofen and dorsal rhizotomy with endoscopic tenoventriculostomy and VP. It's really outside box thinking. It's fantastic. I think the Clash of Titans bring us such a wonderful experience. On behalf of the Education Committee of the ISPN, we are now ending the 12 Clash of Titans. In 4 weeks' time, we have the next Clash of Titans in 19 April. More details will be delivered soon. And thanks very much, Zulma Tovar from UK, talking about baclofen. And thanks a lot, Kristian Aquilina from UK, talking about dorsal rhizotomy. We learn a lot from both of you, and thank you very much for staying with us.
Thank you very much.
For the invitation.
Thanks,